Hello, everyone. I'm Carlos Vergara, one of the Chief Cardiology Fellows at Mayo Clinic, Florida. And we have the honor here of being with Dr. Nicholas Marston, the PI of the no subset study of the VESALIUS-CV trial, and is a TIMI group member and researcher. Thank you for being here with us,
Yeah,
Dr. Marston.
thank you for having me.
So we're going to talk a little bit today about the late breaker that we saw in the session yesterday, the subset study of the VESALIUS-CV, which promises to be and is actually practice changing for preventive cardiology, which is very exciting. Can we start with giving a little bit of a background of the VESALIUS-CV trial so that the audience can remember?
Yeah. No, of course. And actually, maybe even a step before that, the Fourier trial, right, tested Evolocumab, the PCSK9 inhibitor, in secondary prevention, showed reductions in cardiovascular events. And so we've been using it in secondary prevention after patients have MI or stroke. So the reason for the VESALIUS trial was to design a study that looks at patients who are at high cardiovascular risk, but have not yet had an MI or stroke. So kind of a high risk primary prevention group of patients. And they could get into the trial, the VESALIUS trial, with either qualifying atherosclerosis or with high-risk diabetes. And they had to have an LDL above 90 milligrams per deciliter. And from there, it was a large outcomes trial. So patients were followed for 4.5 years after being randomized to Evolocumab or placebo. And the benefit was quite impressive. So in the overall trial, a 25% reduction in major adverse cardiovascular events, the primary endpoint. So a positive trial, and really, I think, impactful in and of itself. The overall trial is practice changing. But here we're looking at, I think, the most important subgroup, which is 3,600 patients who have no known significant atherosclerosis, but do have high-risk diabetes. And that's a group where right now, clinically, we're not treating them. So I think it's an important subgroup to study.
Absolutely. I think that the impact of VESALIUS was so high that unfortunately, the new lipid guidelines weren't able to introduce those changes, but it was so high that there was an editorial that had to be published of saying how much this is going to impact the guidelines. And now, with the subset that we have in VESALIUS-CV, as you well mentioned, we're seeing the patients without known atherosclerosis, high-risk diabetes, but we're blurring more that line of primary versus secondary prevention, where is really the real outcome benefit. We're saying lower is better, right? In this case, with PCSK9 inhibitors. Do you feel that based on these results, are the PCSK9 inhibitors the key of the lower is better? Is this more driven by the LDL lowering? How do you feel like this is translating to that?
Yeah, well, I think first, that gray zone you mentioned is an important one because, we like to think it's primary and secondary prevention, but there is this middle ground. And so even the larger VESALIUS trial included patients, with significant atherosclerosis, including prior coronary or arterial revascularization. And so this subgroup excluded anyone with prior arterial revascularizations. It included anyone with significant arterial stenoses that were greater than 50%. And it excluded anyone with a CAC score of 100 or greater. So really, we were left with a group that truly had no known significant atherosclerosis, and a group we can feel confident calling it truly primary prevention, right? Because they have not had any events, they have not had any revascularizations, and they do not have any known significant disease. And so this is the first study and the first subgroup to study PCSK9 inhibitor Evolocumab in a primary prevention setting. And so that's what's exciting about it. And the results, as you saw, were quite impressive, right? So a 31% relative risk reduction in both of the primary endpoints, so a 3-point and a 4-point MACE. Consistency across all the secondary endpoints, including a significant reduction in cardiovascular death of 32% and a significant reduction in all-cause mortality, 24%. You can't beat a reduction in all-cause mortality, right? That's the ultimate endpoint. So I do think that it moves practice because we're not just reacting to patients having an event or having a revascularization before being intensive and aggressive about lipid lowering. We can be more intentional up front. And as a preventive cardiologist, that's an attractive message to me, is identify the risk early and get the LDL down earlier. And we can talk maybe a bit about how low we should be going with these patients.
Right, and me as a fellow that wants to be a preventive cardiologist, it's so exciting to be this time right now. There's something interesting that we can see in the Kaplan-Meier curves. They start really separating very well after like 1.5 years. That's where I see the curves separating very well. What do you think is that effect from?
Yeah. So, and in the presentation in the paper, we show that that's distinct from the group that has established athero, right? So in those patients that have had revasc and have high CAC scores, we don't see that. We see benefit right away in the first year. So there's something different going on in those without known significant athero and those with athero. Our hypothesis is that those who have significant athero already, they have a large plaque burden. They have perhaps unstable plaques. And so immediately by aggressively treating, intensively treating their LDL cholesterol, you're stabilizing plaques. You even can be regressing plaque because there's more there to regress. But in patients with no or minimal coronary athero at baseline, there's not as much to stabilize or to regress. You're more just kind of preventing the initiation or progression of plaque, and that takes time. So we don't see an effect in the first year, but after the first year, we see a huge effect, 41% reduction in the 3-point MACE after 1 year.
Absolutely. I think this is very important to show our patients where they want to see results. And I think that just the visual aspect of seeing that these results are going to come, and the earlier the better, the longer the better, is going to be practice. It continues to be practice changing. One of the aspects also discussed in the session was the other treatments of diabetes in the trial, and the fact that there wasn't much of the GLP-1s as GLP-2s. Can you just expand a little bit on that aspect too?
Yeah, sure. So, this was a long trial. So it started enrollment back in 2019 before COVID. And so GLP-1s hadn't caught on quite as much. So baseline GLP-1 use was about 10 or 11% in this cohort. SGLT2 inhibitor use was more like 25%. So a fair number of patients were on those therapies. So I think overall, patients who were coming to this trial were well treated and had their other risk factors well controlled.
So this is important to know that in this cardiometabolic kind of health aspect, regardless of the treatment or any other treatments that was for diabetes, just the fact that we treat aggressively the LDL was important. So thank you so much for this insight. How do you feel that this is going to move forward for the new iteration of guidelines or updates that are coming in next year?
Yeah. So if you look at the guidelines that just came out 2 weeks ago, right, which is always exciting, long-awaited guidelines, there's a section for patients really of this subgroup. It's high-risk diabetes without atherosclerosis. So that's exactly who we studied here. And they recommend an LDL cholesterol goal of less than 70 milligrams per deciliter and being on a statin therapy to kind of get there. And if they're not below 70 with a statin, there's a class 2B recommendation to add ezetimibe or a PCSK9 inhibitor. But here we achieved LDL cholesterols in that population of 44 milligrams per deciliter, right, with the addition of Evolocumab, and we saw a huge benefit. So I really think that we should be moving the target for this patient population, be more aggressive and really pushing the LDL cholesterol down below 55 and closer to 40 milligrams per deciliter, which are the targets we use for high-risk secondary prevention. I think that high-risk primary prevention diabetes should be in that same category.
This is going to be very impactful as we continue to move forward. And we thank you and all the investigators to be able to do this monumental work that definitely in the preventive cardiology community we're all excited about. I feel that as a trainee and the people that are coming in the community, knowing that the evidence that is coming behind the importance of primordial prevention is going to really continue to expand the field. So thank you so much. Any last message that you want to tell the audience about the results?
Well, I'll say, I'm glad you're going into preventive cardiology. It's an important field. And it's up to us as kind of academic cardiologists to spread the word about these results, right? Because the population that's going to benefit now from these PCSK9 inhibitors and more aggressive LDL lowering aren't patients we're necessarily seeing in cardiology clinic. We might in prevention clinics sometimes, but the general cardiologists aren't seeing these patients. They don't have athero, right? So we need to educate physicians, primary care physicians, endocrinologists, internists, physicians and providers in the community to kind of get this word out. Hey, we can really help our patients reduce cardiovascular events and even mortality with this, but we need to take action.
Absolutely. That's such an important message. Thank you so much for this interview. It was a pleasure talking to you. I'm Carlos Vergara, one of the Chief Cardiology Fellows at Mayo Clinic, Florida. And I'm here with Dr. Nicholas Marston, the PI of the subset analysis of the VESALIUS-CV trial.
Thank you.